All right, I have another case to go over here for you guys. And I'm new to this whole YouTube thing, so I'm changing up the pattern a little bit. Number one, the case is going to be labeled as like what the case is. I don't want to give away the answers for when you're interpreting stuff. And also, the biggest critique I got was that my mouse wasn't big enough. So I hope this gigantic mouse is big enough for you sons of guns. Last time the riddle was what happens once a minute, twice a moment, but never in 1,000 years. And the answer is the letter M. There's one N in minute, two in moment, but there's no M's in 1,000 years. And again, it goes back to being a doctor is not about what you know, it's about how you think. And I think riddles are a good way to train your brain how to think. That's enough for the riddles. I mean, you get the point. This case comes from Dr. Nemo. He's one of our first-year residents at UTMC. Here's his picture. Word on the street is he's a bad commissioner at fantasy football. Like, he's a tyrant, apparently. And some of the other residents had to come together and have a No Kings rally outside of his house. But here's the case he sent us, okay? Patient is a 40-year-old male who presents with a chief complaint of chest pain. This started while he was at work. The patient is a bartender. States he has a history of diabetes, hypertension, non-compliant with medications. He felt a pressure in his chest that radiated to his arms. Got lightheaded, denies any nausea or vomiting. Again, you don't treat an EKG, you treat a patient, and the value of any EKG depends on your pretest probability, and the history comes from our pretest probability. He's 40, okay, that's not too old. He was coming with chest pain, which is concerning. It happened while he was exerting himself. He describes it as pressure, and he says it radiated to both arms plural, okay? Again, in my experience, anytime someone tells me they have radiation in both arms, it's only a matter of time before they end up needing a stent during their hospital stay. And he also has risk factors, okay? Diabetes and high blood pressure, and he is non-compliant. So relatively high pretest probability. Let's look at a previous EKG, because remember, it's always good to establish a baseline, okay? Same thing, pause, write down your findings, and then think about what your interpretation is. And remember, interpretation is the action of explaining the meaning of something. All right, so here's what I see. Let's just go through the basics. Number one is the rhythm. All right, here at the bottom is called a rhythm strip for a reason. Just read it from left to right. There's 1P for every QRS, normal sinus, and let's move on. The axis, I would say it is borderline left. Okay, it's up in lead one, mostly up in AVF. Okay, it's either normal or left. And again, in my practice, I'm not too concerned about a left axis deviation. For intervals, I don't see any real widening of the QRS, and I don't see any prolongation of the QT. And for ST waves, I do see some ST wave abnormalities. There's many to point out here. Number one is in the precordial leads, okay? Right here in V2, if we look closely, there is some J-point deviation from the PR segment here. It's approximately 1 millimeter. You can make the argument that this is consistent with a hyper QT wave because it's relatively tall, especially tall when we compare it to the amplitude of the QRS. Down here in V3, not too much J-point deviation, but again, a relatively hyper QT wave. There is some J-point deviation over here in lead 4, and we can see a little bit of Spodek sign here too, like downsloping of the isoelectric point, as well as a U wave. Same thing in V5. Again, these are non-specific. We do have pretty big P waves in the precordial leads. They're not biphasic. That could raise the concern for atrial enlargement. There's a little bit of slurring of the QRS here in lead 2 and fractionation that we can see in 3 and AVF. Again, a fractionated QRS is a sign of structural heart disease. There's something electrically inert that the electricity has to go around, and that's why we see that slight delay in the QRS, but it's not a block because it's less than 120. And again, we have J-point abnormalities and reperfusion abnormalities in lead 1 in AVL. If we look closely, there is maybe 0.5 millimeter of J-point elevation compared to the PR segment in AVL, and maybe the same in lead 1 as well. And also, we see this focal Spodek sign here as well, too. Okay, so overall, my interpretation is this is non-diagnostic and non-specific. This was just an EKG this patient had before he went to surgery. And this EKG Does point out the fact that, remember, we don't treat an EKG, we treat a patient. This was just a screening EKG prior to a procedure. In the proper setting, this could be concerning, right? I mean, because we have focal repolarization abnormalities. The patient has risk factors as well, but if he's not having symptoms, then we shouldn't be that concerned. What was I going to say? What else was I going to say? Oh, yeah, you can really see here, which highlights the Spodek sign. I mean, look at lead 2. Like the isoelectric point from the end of the T to the P is like perfectly horizontal. And these other leads, specifically lead 1, AVL, V4, 5, and 6, we see this downsloping again, which is non-specific, but does count as a focal repolarization abnormality. Here's the EKG the patient had on arrival at the hospital. This was 2059. Same thing. Pause, write down your findings, and think about your interpretation. All right, so here's what I see. Let's just go over the basics. Again, normal sinus rhythm. We have 1P for every QRS. The axis is normal. It's up in 1 and up in AVF. For the intervals, I don't see any widening of the QRS, and I don't see any prolongation of the QT. For ST waves, we have multiple nonspecific ST wave abnormalities here. Let's look at the precordial leads. Okay, remember in his previous one, he had an upright T wave in V2. Now we have an inverted T wave in V2. Again, if you'll notice, there is this delay within the QRS, but it's not a block because it's less than 120, consistent with a fraction of QRS. We see that in other leads as well. We see here with the slurring of the S wave in V3, you can see it really good in 2-3 and AVF, like this forward slurring of the S wave. I mean, that almost looks like WPW, like a short PR and an S wave, but I don't think it's WW because we don't see a definitive F waves in all leaf. I mean, here, maybe there is some delta, but I don't think it's WPW. I think it's more structural heart disease. Also, if you notice, we have this like inverted P wave in V1 before it was upright. That is suggestive of left atrial enlargement. Also with V2, not only is this ST segment inverted, but pay attention to the initial direction of the vector of this ST segment. Remember, ST segments that are linear, horizontal, and or downsloping are concerning. Okay. What else do we have here? Again, you can make the argument that there is some hyperacuteness of the T waves. But again, the question is, well, is this an infarct? The answer is, well, no, it doesn't qualify for an ST elevation myocardial infarction, but we do have these repolarization abnormalities. And again, one other thing to note here is we have focal U waves, okay? In these precordial leads, V3 and V2, we can see a pretty good clear-cut U wave. We don't really see that in much of the other leads. I mean, maybe a little up in lead 1, but I mean, it's pretty clear-cut only in these leads. Again, for me, I get concerned when you have the trifecta of risk factors, symptoms, and focal repolarization abnormalities, which this guy has, right? And we know from his history, he's got risk factors. Okay, he's got high blood pressure, he's a diabetic, he's got concerning symptoms, he's got pressure that started when he was exerting himself and goes down both arms. And now we have these focal repolarization abnormalities. That's highly concerning, okay? Here's a repeat EKG at 2153. I mean, we see the same abnormalities that we've had before. We still have this inversion in V2, the same fractionated QRS that we saw all over the place. We do see maybe some more J-point deviation over here in the lateral leads here, right? Remember, my opinion is always compare the J-point to the PR segment when you're worried about infarction or ischemia. And when we look here, there is maybe 1 millimeter of J-point deviation in V5, maybe a 0.5 to 1 in V4, same thing in V6. And again, this highlights two things. Number one, the Spodek sign, and number two, why we should use the PR segment as our isoelectric point when we're thinking about ACS and not the TP segment. Because if you look at these two leads, if you look at the TP segment and you extrapolate it out, it goes right through the J point. Another thing, serial EKGs are very valuable, right? Like this EKG is literally only 10 seconds from when the time is of the patient in the ER. Like an EKG is a non-invasive, simple test. It takes 10 seconds to do. You're never wrong to do a repeat EKG, especially if your patient still has symptoms, right? And again, we see those subtle changes compared to the previous one, right? Like before V4, 5, and 6, there wasn't much J-point deviation. Now there is. And he had a 30 kg the next morning at 3:30. Again, is this an infarct? No, but we have Again, focal repolarization abnormalities. Like the rhythm is still normal sinus rhythm, axis is okay, intervals are okay. For ST waves, that inversion in AVL has now gone back up to upright. And we still have J-point deviation. You can see it pretty well right here. Maybe 1 millimeter of J-point deviation in V2 as well as V3. And again, we have this development of this hyperacute T wave. Like, look at V2 and V3. If we were to copy these QRSs and paste them underneath the T wave, almost the whole thing fits under the T wave. That's our hyperacute T wave. And again, like, look at these nice focal U waves that we have. I mean, and look at 2-3 and AVF, like the isoelectric point perfectly straight, like no U waves whatsoever, and now we have these more prominent U waves. Again, is this a STEMI? No, according to the guidelines, but he has symptoms, risk factors, and a focal repolarization abnormality. So what happened while the patient was in the emergency room? The ER doctor was astutely concerned, and he called a STEMI, and the STEMI was canceled. Okay. Here's what happened with the patient. First troponin 852, second one 781, third one 52,000, fourth one 80,000. Okay, goes to cath subsequently, and he's got severe disease that needed to be fixed with intervention. Here's the concerning thing down here: left ventricle, mild increased thickness, systolic function is normal, hypokinesis at the base of the heart. So that's bad because that means we have dead heart tissue. The right ventricle is borderline dilated, systolic function is normal. So that's the thing for this gentleman. This area of hypokinesis or dead heart tissue, I cannot definitively tell when that happened. I mean, because when we looked at his previous EKG, where did it go? Yeah, this one, I mean, he already has this fractionated QRS. I mean, is that where, this is coming from? Is this fractionated QRS subsequent to that dead heart tissue? I mean, I would say probably. And if it was here before, I would say, well, it's probably not from this current infarct, but that's not definitive. And I didn't see an echo for the gentleman, so I don't know what's going on with his valves. And again, forgot one thing. So his first EKG, his first two EKGs, we had this inversion in V2, right? And then on his third one, it goes back up to upright or a normal appearance. That's not always good. I hear all the time people say, "Oh, I'll repeat the EKG and it looks better." That's not necessarily a good thing. That's what's called pseudo-normalization. Like when you go from a chronically abnormal appearance to a normal appearance, that can be a sign of a critical stenosis or occlusion of the vessels. And just so you know, I'm not making it up, like here's the literature on it. And to highlight a case of that, this is a case I had before. 6-7-year-old female for chest pain. She reports to be experiencing pressure-like pain in the left side of her chest that radiated down her arm for the past 30 minutes. So the key thing for here in our pretest probability, these symptoms started just half an hour prior to arrival. Here's the patient's previous EKG. Things to note is her normal is always abnormal. Like she has these T-wave inversions in 3 in AVF, V3, V4, V5, and V6. That's technically abnormal, but that's her normal. Like normal is my least favorite word in medicine. Normal means conforming to a standard or what's to be expected. So her standard or what's to be expected is abnormalities. Now, when I saw her, here's her first EKG. I mean, there's many things on here which are abnormal, but the things to note is the upright appearance now, these T waves in 3 AVF, V3, V4, V5, and V6. See, this is like a normal appearance. This is what you would expect to see, but for her, this is a pathologic finding. Like from going chronically abnormal to normal is also pathologic. Other things to point on here, which are interesting, is again, this inversion, depression, and linearity in AVL. In my opinion, this finding is the most sensitive finding that there's an occlusion somewhere in the coronary arteries. Because these EKGs, all we're doing is measuring the passage of an electrical vector through the myocardium of the heart. If you have a problem with blood flow anywhere in the heart, left, right, posterior, anterior, the overall vector which is going to be affected most is top right to bottom left, which is what AVL is. And again, note the proportionality of this linearity. Like, again, if we were to copy and paste this, it's over half the amplitude of the QRS. And here's what happened with her. Elevated troponins, went to the cath lab, and she needed repair. So the whole point for this EKG is, well, what is a STEMI? I mean, because neither one of these cases I presented to you qualified for STEMI criteria. If the question is, what is a STEMI? This is my most current answer, and this comes from the American Heart Association. Like, this is the amount of elevation which leads you have in order to qualify for a STEMI. And again, you can depend on which lead it is, your age, and your sex. My whole dynamic, or my whole process of thinking is that the term STEMI and the need of thinking about STEMI should change. Okay, because again, STEMI is a relative term. What a STEMI is depends on who you're talking to and what you read. And this paper kind of highlights this dynamic, which I think needs to change. Okay, in this paper, they're talking about, so STEMI or STEMI equivalent, yeah, they need to go for emergent cath. Everything else, you don't need to cath them emergently. We can wait and see what happens. And here's what they define as either a STEMI or STEMI criteria. Okay, these first three, the posterior STEMI, the left bundle branch block with scarbosis criteria, or Smith modified, are their STEMI equivalents. De Winters or hyperacute T waves are not. Okay, so if you have De Winters or hyperacute T waves, you don't need an emergent cath. Okay, same thing, like these are the findings that they qualify as ischemic and are not in need of emergent revascularization. And that's where I disagree with. I mean, these things are all focal repolarization abnormalities. My opinion is when you come to the point of symptoms, risk factors, and focal repolarization abnormalities, it's not a question of does this patient need a cath, but how soon do they need a cath? And there is literature out there, and there's other people who are along this same process, and what they're pushing for is to more qualify this not necessarily as a STEMI, but as what's called an OMI, or an occlusive myocardial infarction. And that's what I'm referring to. Well, STEMI is not necessarily how we should be thinking. We should be thinking, does this patient have an occlusion, and how soon do I have to fix it? This is a good paper. I recommend looking it up and reading it at your leisure. I cannot do it justice. Here's some interesting facts from it. This one is pretty concerning. 56% of individuals with acutely occluded coronary arteries do not exhibit ST segment elevation. That's very concerning. And here's more from their paper as far as the difference between thinking about STEMI and OMI and the EKG findings that they're talking about. Again, you can look all this up and read through them, but they're all just focal repolarization abnormalities. Like this is the South American flag sign they're talking about, elevation in non-contiguous leads. You have it 1, AVL, V2, and V3. It's supposed to make this Y pattern like the South American flag. I was going to try for a South American accent, but I can't do it. Again, it's nice to know this, but if you're looking at it, it's just symptoms, risk factors, and focal repolarization anomalies again. And again, there's things on here which are concerning. Again, look at the linearity of this ST segment outside the baseline. And also, if you look at our case, this patient's previous EKG almost looks like that South American flag sign, right? Like he's got J point elevation in V2, AVL, lead 1, and inversion in lead 3. Like it looks like that Y pattern, that South American flag pattern. And again, he had this just before he had his surgery. You don't treat an EKG, you treat a patient. I mean, it's interesting. I didn't ask the guy, but was he having pain when they did his EKG? That's something interesting to think about. But again, just boils down to focal repolarization abnormalities. Here's the Aslanger pattern. Again, they pointed out, and you can look it up, but again, it just boils down to a focal repolarization abnormality. Here's De Winters T waves. The definition is J-point depression with a rocket upsloping hyperacute T wave in the precordial leads, which we have here. Again, it's not an infarct, but it is a STEMI equivalent. Also notice other findings on here which are concerning is we have a T wave in V1 bigger than V6. So what does the literature tell us? The issue is, in my opinion, looking through the literature, it's inconclusive. I mean, you can find evidence on both sides. You can find papers that advocate for early intervention and papers that say, well, intervention doesn't really change much. I like this paper. Again, in conclusion, early invasive strategy may lead to lower mortality rates. This one as well. I found this one very interesting. This one came out of Korea. Again, conclusion, early invasive strategy. This one, you can see in this graph right here, what they went by was the symptoms, the time frame from when your symptoms started to when you got caths, which I'm not very well read, but I've never seen before. And I like this thought process, right? Because it's the same thing with a stroke, like when's the last time you were normal? It's good to approach that with myocardial infarction because it's the same thing, like it's an ischemic process. Well, like when did your symptoms start? And that's something you really have to nail down on your patients. Because Again, the pain from their infarct, they may have been having chest pain on and off for a couple days, but I mean, what you got to get from them is, all right, the pain you're in right now, sitting in this bed, like how long ago did this pain start? And you can see from this paper, the time point was 48 hours. Like before 48 hours from time frame of symptoms, you can see there's definitely like an increase in good outcomes. Afterwards, not so much. Again, another paper, early invasive strategy was associated with lower risk. Again, but you can find evidence on the other side too, right? Like this is from the Swedes. Not only do they give us good data, but they give us good fish candy. This data did not provide support for any early invasive strategy. Same thing with this paper. Okay. In conclusion, all comers with non-esophageal and early IS does not reduce all-cause mortality. And again, like everyone's different. And if you're listening to this video, like I'm not on here to try to convince you that I'm right or you should practice like me. I'm just telling you what I think and why. And I am very aggressive with coronary artery disease. And one of the reasons is it remains to be a leading cause of death. I mean, it is literally the leading cause of death all the time. So that's why for me, STEMI is an antiquated term, and we just think about symptoms, risk factors, and focal repolarization abnormalities. So that's all I have for this case. In conclusion, again, in my opinion, we should not be thinking as STEMI. We should be thinking about, does this patient have an occlusion in their coronary arteries? And for me, the trifecta is symptoms, risk factors, and focal repolarization abnormalities. That's all I got. Peace out.